Hello and good afternoon. My name's Annabelle Crabb, and I'm thrilled that you could join us today for the latest breast cancer trials Q&A. Breast Cancer Trials is the largest independent oncology research group in Australia and New Zealand, and they've been conducting clinical trials research into the treatment and prevention of breast cancer since 1978. Thank you so much for joining us for tonight's edition of Breast Cancer Trials Q&A. We're going to be talking about whether young women in greater numbers are being diagnosed with breast cancer. I think we've all had the experience in the last year or two of looking at news sites and seeing more and more stories about young people being diagnosed with various kinds of cancers. What we're going to look at tonight is the incidence of breast cancer in younger women, hear about the patterns, and learn a little bit more. So welcome to you all, whether you are at the beginning of, in the midway through, or the concluding stages of your breast cancer journey, or you're caring for someone who is, or you're just wanting more information. Our very warmest welcome to you, and thank you for joining us. Our panel of experts, and that's the great thing about these sessions, is that we put together a great brain bank of experienced and smart people to answer the things that are keeping you up at night. Before we go and meet them, however, I do have a tiny bit of housekeeping. First of all, I'm joining you from the lands of the Gadigal people of the Eora Nation. I know that we're being joined by around 1,200 people from all over Australia and New Zealand. And so I'd like to take a moment before we proceed to thank and acknowledge the traditional owners of wherever it is that you're dialing in from, and recognise their ongoing role in care and custodianship of this great region of ours. Now, in terms of technically handling the Q&A this afternoon, I am not in control of the technical side of things. You'll be relieved to hear. And this is just a user guide to the session, if you move your mouse over the screen, in the bottom right-hand corner, you'll see three little dots. That's the technical scientific term, three little dots. Hover your mouse over those dots and you'll see some options. You can make a comment or send a question if you click on Ask a Question. And that's a handy little trio of dots, because if you experience any technical difficulties during the webcast, first of all, try refreshing your browser in the first instance. And if you're still having issues, click Info to find the link to access live chat support. But in any event, do not panic that you're going to miss something, because this entire Q&A is being recorded. So if technical issues prevent you from seeing the whole thing, we'll be sending a link to everybody tomorrow to be able to watch the whole event. And of course, you'll be able to forward it to anybody who you think might be interested in any of the issues that have come up during our discussion. Okay, let's crack on. I'd like to introduce our guest panel who gathered to answer your questions today. And thank you to everybody who's sent in questions. There's always strong interest when we gather great minds together. First of all, I'd like to welcome back Emma Crowley from the Breast Cancer Trials Consumer Advisory Panel. Emma was diagnosed with HER2 positive breast cancer at the age of 24, which is very young. And every time we do one of these Q&A sessions, we're joined by somebody who has walked the hard road of experiencing and being treated for breast cancer, and we're so grateful for those who stick around to share their insights to those who are starting out and are feeling confused and overwhelmed and a bit frightened. Thank you, Emma. And I will also say happy birthday. It's Emma's birthday today, and she has chosen to spend it talking about breast cancer, which is probably, of the topics in her life, the one that contains the least joy for her. Thank you so much, Emma, for your generosity. And I'll come to her shortly. Professor Vivienne Milch is the Medical Director at Cancer Australia and is also the Medical Advisor to the Australian Commonwealth Department of Health, Disability and Ageing on cancer screening policy. And you may have seen Cancer Australia talking recently about young people being diagnosed with cancer, and she's a very welcome and new presence on our Q&A panel today. Another familiar face, if you've been in attendance at one of these events before, is Associate Professor Leslie Stafford. Leslie is a clinical psychologist and an academic psycho-oncologist. She's an associate professor in the Department of Surgery at Melbourne University and also works in private practice. Welcome back, Leslie. And another returning face is Dr. Wanda Swee, who's a medical oncologist in the breast cancer service at the Peter MacCallum Cancer Centre in Melbourne. Welcome to all of you, and thank you for giving your time to convey intelligence and information to an interested and large group of people. Now, I'm going to start the Q&A with this video, just showing the range of questions that Breast Cancer Trials has received on this topic when they did a shout out. Let's roll the video. So I think you can see from that spread of questions, there's a combination of people thinking about treatment and how it works in women across the age spectrum, and also some people who are obviously reading headlines and worrying about their risk of exposure to breast cancer at an age younger than what we have usually assumed that it arrives in people's lives. Now, speaking of which, Emma, I'd like to bring you into the conversation now, but start by wishing you a happy birthday. Have you had an opportunity to have some cake yet, or is that a post Q&A spectacular?
The cake comes after. Pizza first, Q&A, and then God knows what cake.
That just seems like
made by the children.
That seems like a decent order of events, Emma. And once again, on behalf of all of us, thank you so much for taking a chunk out of your time with your family to do something brave and hard and generous, which is to revisit a time of your life that wasn't the most happy part. So you were diagnosed with breast cancer at the age of 24. Could you start by just telling us how that happened and what it felt like to you?
Yeah, so I had been acting like an ordinary 24-year-old, and I actually been out with friends, and we'd had quite a big night. I don't know if that's a secret. And so I was feeling a little dusty, and I went to shave my armpits, as you do, and it was my right side, and there was this large lump, huge actually, and it was sort of protruding out of my armpit, which was unusual. And I don't shave my armpits daily. I don't know, maybe I did, but anyway, it didn't feel like it had been there the day before or even 2 days before, and it's something you do quite often. So I thought that was a bit odd. I went to the doctor and they said, "Oh, could be a spectrum of things. Let's not get too excited." The spectrum being just a cyst to being cancer. Go and have an ultrasound. So I went and had the ultrasound, and then there were actually two lumps, one behind each other in the lymph nodes, the size of golf balls. And he said, "Oh, I think you should have a biopsy." So I went off and had the biopsy. And then I was actually in Wellington, New Zealand based, for work. And the GP called me and said, "You need to go and see a breast surgeon." And I said, "Okay, well, when?" Because I'm in Wellington for work, so I can't do that tomorrow. He said, "Well, you kind of need to do it quickly." I said, "Why?" And he said, "Well, just come back to Auckland and come in and see us." I was just tell me. He said, "No, we'll just see you on the weekend, but make sure you bring someone with you." So I but I was really naive. I didn't think that I don't take instruction well, as many will tell you. And so I didn't, well, I did take someone. I took my, we had a baby at 20. So my daughter was 4 or nearly, yeah, she was 4. So I took my 4-year-old and no one else
Emma.
after her swimming lessons. And I looked in and the GP wasn't my normal GP. It was like, oh God, she's not one to take instructions. And they didn't really have a choice because it was a Saturday morning. They'd been waiting for me. So they just had to, dump the news on me and then said, we can't let you go though, because notwithstanding you don't listen to anyone, we're not going to let you drive home.
Okay.
So
Had you ever thought about breast cancer? Did you have any family history of breast cancer?
nothing. My parents' friends that had breast cancer. I didn't know anyone my age that had breast cancer. I didn't have a family history of breast cancer. I don't have a family history of breast cancer. I don't have the genes or any known genes. It was just bad luck.
Okay, so there you are in this room. They won't let you leave. You've got a 4-year-old to look after. What did you do next?
Everyone sort of wrapped around me. Wayne, my partner, husband, whatever you want to call him, came down. My parents, I grew up in Wellington, so my parents weren't here. So I rang them and they got on a plane and came up. I rang anyone and anyone that would listen, basically, which is, I think, what you do, right? When you're that young, you've got really close friends, so you sort of ring round and you're in a bit of shock. And I think my way of dealing with the shock was to just talk incessantly at anyone that would listen. So I did that. And actually, a really close family friend had recently had breast cancer, and my mum must have rung her and said, this has happened. They are based in Auckland as well. And it was Labour weekend in New Zealand, so that's October, Breast Cancer Month. And she rang and said, my oncologist wants permission to access your file to see the biopsy results. And so I said, well, yeah, okay, cool, I don't care, just access whatever you like. And then they rang back and said, you need to go and see him on Labour Day. And it was the Saturday, and by the Monday, the public holiday, I was in his office. And he was like, right, this is some serious stuff.
Okay, so when people are responding with that degree of urgency, even you who can't be told anything must have been thinking, well, this is some pretty dark news. Everybody seems to be working on a public holiday. What type of breast cancer were you diagnosed, and what did you understand about how serious it was and what treatment you'd need?
Initially, and because I was naive to these things, thought cancer means death. Mm-hmm. So that was my initial reaction. And so I spent sort of 24 hours with that running around in my head. And then I went to the oncologist and they did all the testing, and I had HER2 positive. So I didn't have any estrogen or progesterone markers or whatever you want to call them. I just only had HER2 positive. And so we just focused on that, and it was really aggressive, which it tends to be in young women. And that was evidenced by the speed at which it had moved to my armpit. And I was really lucky. I had private treatment, and he just laid out kind of the pathway, the couple of options. You have this sort of the standard of care at the time in New Zealand. You can have this thing that the Americans have, which will cost, tens of thousands of dollars, or you can have this middle of the range thing, which will cost you $10,000 in total. And all credit to my parents, they didn't skip a beat. They were like, $10,000 done. Where do we send a check? Like, get her the drugs and get her on them tomorrow. And the advice was she needs to start the oral treatment tomorrow. And so I did. And so I'm very conscious that that's not everyone's experience, and that's a very privileged experience to have. But it was terrifying. I deferred to everyone at that point. I started listening.
Yeah. Okay. Thank you, Emma. I'm going to come back to you in a little bit to talk about your experience of treatment and what it was like. But I want to cut across to Vivian for now, just to give us an overview of what the average age of breast cancer diagnosis is, and are the majority of breast cancer cases post-menopausal women? I think that's what I've always assumed.
Yeah, so thanks, Annabelle. I think the thing that we know is that still the two most common risk factors for breast cancer are being a woman and getting older. And we know that the median age for diagnosis of breast cancer in Australia is around 63. And still, the majority of people with breast cancer are over the age of 50. So we estimate that this year in Australia, there'll be more than 20,000 people diagnosed with breast cancer. And of those, we expect about 3,900 of those people to be diagnosed in those under 50.
So I guess one of the reasons that many people will have tuned into this Q&A today is it seems perceptible from news reporting, and I won't say for a second that me and my colleagues are always 1,000% reliable in delivering an accurate picture of trends and so on, but are more young women being diagnosed with breast cancer as a proportion of total diagnoses today, and in what particular age groups?
Yeah, so we are aware of this phenomena, which has been called early onset cancers, or an increased diagnosis rate of people being diagnosed with cancer in that age group of 20 to 49, and often with cancer subtypes that we traditionally see in older people, and that includes breast cancer. So we have seen a increase in that age group. It's only a small percentage increase, but I guess because breast cancer is a very common cancer, even a small percentage increase can be a significant number of people. So we've seen a small increase in people 20 to 39, a slightly bigger increase rate in people 40 to 49. And I guess a critical message, and a lot of people are spending a lot of time looking into this to try and work out whether there is anything new in terms of risk factors, or whether it's actually just the confluence of things that we know are risk factors for breast cancer. But very importantly, and a critical message, is that we are seeing a reduction in mortality, so an increase in survival for young people, for all people with breast cancer, but including young women with breast cancer. And those percentages have really increased from like the mid-70s to over 90% 5-year survival, and mortality halving really in the under 50s over the last 30 years.
So yeah, I think that's a really important thing to remember at every step of the way, the extraordinary increase in survival rates after a diagnosis of breast cancer over the last few decades. And of course, that is significantly due to research and trials such as those that are created and provided by Breast Cancer Trials. Vivian, is it possible that this uptick of younger women being diagnosed with breast cancer is about nothing more than an increased awareness, an increased understanding of what to look out for, or is it an endemic increase that is significant on its own?
So I think it's, a combination of all of those things. We are seeing an increased number of people having screening tests in their 40s, and that will increase the number of early stage diagnoses, which is a good thing. Early detection is good. We also know that there's increased awareness in the community of things to look out for, and that's also good. it's really important that women get to know the usual look and feel of their breasts and actually know what's different for them and go off to see their doctor if they see something different. But, you know, there are a number of other factors that probably play into this as well. And one of those is genetic factors. So a certain, you know, small proportion of women diagnosed with breast cancer have a inherited genetic fault. But there are also lifestyle issues, drinking alcohol, physical inactivity, overweight and obesity, those sorts of lifestyle issues which play into increasing risk of breast cancer, and reproductive issues too. You know, we know that women are putting off having children later. We know breastfeeding is very good, you know, in terms of reduction of prevention of breast cancer. So there's sort of some reproductive things going on too. So I think we are seeing you know, something that is multifactorial. There's lots of different things that play into it. But, you know, very similar to Emma's story just now, that you can have a number of risk factors and never develop cancer. And you can develop cancer and have no risk factors, no family history, no genetic risk, you know, not have any of those factors that I've just mentioned. And just sometimes it is just a matter of chance, I guess.
Vivian, in Australia, I guess there's a sort of a psychological signal sent by the age at which we start reminding women to have to undergo breast screening. Does that have the effect of people thinking that they're not at risk until they're 40? I think it's worth making clear that in Australia you can get a free breast screen before you're 40 years old. I wonder, I don't even know if it's the same in New Zealand, and apologies for my ignorance, but I know we've got people joining us from New Zealand. Are the same patterns evident in New Zealand, A, and then B, can you ask the question that I asked first? Answer the question I asked first in this increasingly convoluted piece of interrogation.
Yes, absolutely. So this is a phenomenon that we are actually seeing in Australia and across the world, particularly in the developed world. So New Zealand, UK, US, we are seeing those same sort of increases across the board and in younger people. So in Australia, we're very lucky to have the Breast Screen Australia program. It does, you can actually, through Breast Screen, have a free mammogram every 2 years from the age of 40. It specifically targets people 50 to 74 years old, because that's where the optimal benefit of screening happens. In that younger age, 40 to 49, there's still benefit, but there's also an increased risk of a false positive or a false negative, being reassured that you don't have cancer, but there is cancer there, or having to have unnecessary investigations. And so that's, you know, that's why we don't target people 40 to 49. But under the age of 40, there's actually...
I said 40 when I meant to say 50.
Yeah, that's okay. That's okay.
But I think I'm 42.
Yeah. So under the age of 40, you're right though. Screening mammography is not effective for women under the age of 40, but that doesn't mean that you can't get cancer at a younger age. So it's really important to be breast aware, and that means looking out for symptoms that aren't right for you, and that might be, you know, a lump or a lumpiness, particularly in one breast. It might be something that's not right with the breast, with the nipple inversion or crustiness, or something that's not right with the nipple. It might be an unusual pain that doesn't go away, or a difference in the size or the shape or the look, the skin of the breast. So I guess the thing to say is that, you know, 9 out of 10 breast changes are not due to cancer. But if you notice something that's not right for you, you need to see your GP without delay. And of course, that's what happened to Emma. She had noticed a symptom, she went straight off to her doctor, and that's exactly the message that we are trying to impart to the community.
Great. Thank you, Vivian. Thank you for all those excellent tips. I want to cross now to Wanda Swee, who I'll remind you is a medical oncologist in the breast cancer service at the Peter Mac Cancer Centre in Melbourne. Wanda, welcome to the panel. Thank you for joining us once again. As our medical oncologist here, have you seen a growing trend of younger women in the clinic with breast cancer?
Thank you for having me, Annabelle. I think, to echo what Vivian has mentioned, I think we are seeing increasing numbers of women diagnosed with cancer across the board, which includes younger women. I'm looking at my clinic over the last few weeks. About a quarter of the patients I see in clinic are under the age of 50, which really corresponds and correlates to some of our national data, where approximately a quarter of the women diagnosed with breast cancer in Australia are under the age of 50. I think also contributing to the increase numbers of women we see is because our treatments, particularly systemic treatments, which I deliver as a medical oncologist, have improved so dramatically over the last few decades. And we've got more treatment options and our patients are surviving longer. And so we're following them up for longer from a surveillance perspective.
Okay. So how does it work in terms of premenopausal and postmenopausal women? Does the biology of breast cancer work differently in those age cohorts?
So I guess what we do know is that certain types of breast cancer, such as triple negative breast cancers and hormone receptor negative breast cancers, as Emma highlighted earlier today, are more commonly seen in premenopausal women compared to postmenopausal women. But still, hormone receptor positive cancers are still the most common cancers we see in both groups. We also know that breast cancer is associated with genetic mutations in the small proportion of the population who have these mutations are often diagnosed at a younger age. And so when we do see younger women with a diagnosis with breast cancer, we do need to think about genetic testing in these patients. But certainly the majority of patients we see, both younger and older women diagnosed with breast cancer, don't have a genetic mutation as a cause of their cancer.
And when we were talking to Emma a minute ago, she said that her cancer was very aggressive, which is a common feature of younger women being diagnosed with breast cancer. Why is that? Is that right? And how come?
So I guess some of the more common types of breast cancer that we diagnose in young women, such as triple negative breast cancers, do have a more aggressive a more aggressive biology, and so therefore these cancers can grow faster. They're more responsive to treatments like chemotherapy, and so that's, I think, part of the reason why this concept of more aggressive cancers in younger women.
Okay, so what about the risk factors? I mean, as a woman, do my premenopausal risk factors differ from my post or perimenopausal risk factors? Does it change over the course of my life?
So I think this is a really good question, and I think that this is something that a lot of research is still looking at. As Vivian highlighted, the biggest risk factor for breast cancer is being female and increasing age, which are non-modifiable. There are also other non-modifiable risk factors such as family history, as well as inherited genetic mutations. And as I mentioned previously, often patients with genetic mutations are often diagnosed with their cancers at a younger age. There are a number of non-modifiable risk factors, as highlighted previously, including things like alcohol intake, pregnancy and breastfeeding, as well as obesity and physical exercise. We know that obesity seems to be more linked with postmenopausal breast cancers rather than premenopausal breast cancers, but certainly the other risk factors I've mentioned before, as well as exogenous hormone use, so things like the pill, can also increase risk of breast cancer. Often it's not one risk factor that has increased a woman's risk of breast cancer, but the combination of all of these risk factors. And sometimes, as Emma and Vivian highlighted earlier, some women have none of these risk factors and still develop breast cancer.
Okay, so if we can zoom in for a second on genetic mutations like BRCA1 and BRCA2, are those mutations being detected more frequently in young women?
So I guess the short answer is I think in short, I don't think they're more the frequency of these mutations is not increasing. However, the testing availability that we have now has improved. And we're also now testing for other genes that confer a high and sometimes moderate increase of breast cancer, genes like TP53, PALB2, CHEK2. And so I think because we are better at testing is more available, we are detecting more patients who have an inherited germline mutation, but I don't necessarily think that means genetic mutations are more common in the population. Right. And certainly, only about 5% of breast cancers patients with breast cancer have an inherited gene that put them at risk of developing their cancer.
Okay, all right. Thank you, Wanda, for explaining that so carefully and clearly. Leslie, I'm going to turn to you now. You're our psychologist on the panel. We always try and have at least one. And just to remind our viewers, Leslie Stafford is a clinical psychologist and an academic psycho-oncologist who's an associate professor in the Department of Surgery at Melbourne University, also working in private practice. Leslie, what are the particular challenges that young women with breast cancer face that distinguish them from the experience of postmenopausal women?
I think that the biggest challenge all women face with breast cancer is the worry that their cancer will come back or get worse. And so that's not particular to young women. That's, as I said, all women. I think specific to younger women is probably more the issue around young dependent children, whether that's the impact of treatment on their role as parents, or whether that's the sort of crushing worry that they, perhaps won't be around to see their children grow up. I think motherhood really does strip us bare. So I guess along similar lines then is that impact on fertility and the extent to which cancer treatment compromises fertility and changes childbearing plans. I think younger women are also more likely to be affected by concerns about their body image and their sexuality and the role this would have in attracting or maintaining a romantic relationship. And we can't, sort of skip over the part where women in their 20s and 30s and 40s are building or consolidating a career, and that is often profoundly interrupted by diagnosis. So there are lots of lost opportunities. I think also young women tend to express more of this sort of loss of trust in their bodies because there's an extra feeling of feeling betrayed by something that shouldn't have happened at such a young age. So there can be a real sort of existential struggle with meaning and with fairness of why me. It's incredibly isolating, I think, to be a young person with breast cancer when, as you say, the sort of Vivian said, the median age of breast cancer is about 63.
Yeah, by which age you're more or less reconciled to the fact that your body is, not capable of everything that it once was, right? But it's like being, I guess, hit by a truck when you're very young, to learn that something is going wildly wrong with your body that you didn't know about, that has come to you as a complete surprise. I mean, how do you see young women coping with that, and how do you help them through that massive download of shocking information for which they weren't prepared?
So, it's very scary, I think, when you look to the future and it looks uncertain for you. It's confusing and frustrating, for young women like Emma who have no family history, no real risk factors. How do you sort of make sense of that? And, as someone else mentioned before, only a small number of women of breast cancers are due to inherited mutations. So the sort of chasing, why this has happened is often futile. And I often say to women, if you knew, what would you do? What could you do differently now? And that's often the reason we want to know, so that we can prevent it from happening in the future. So we may never know, but we can still choose how we live forward. And so what I like to do with women is to is to show them that they still have a lot of power over how they care for themselves, physically, emotionally, spiritually, that they can make healthy lifestyle choices, like others have said, in terms of exercise and nutrition, that they can take good care of their mental health, turning their sort of experience, I guess, into purpose. So I encourage the women I look after to explore what gives them meaning rather than what gives them answers, and to think of their life unfolding ahead as building something new that's been shaped by what they have learned and what they've survived.
Obviously, Leslie, as anyone who's experienced depression or cared for someone with depression knows, it's when you're very depressed that you are at your least able to exercise and jump up and eat healthy and do all of those things. And I want to direct to you a question from Sharon, who's written in to ask, what is the impact of depression among young women diagnosed with breast cancers? She personally feels that her anxiety and depression have worsened since her diagnosis. And before you answer, Leslie, I'd just like to say, Sharon, hello, and I'm horribly sorry to hear that you've had this experience and that you're struggling. And I'm so glad that you joined us for this session. Leslie, have you got some things to say?
Yeah. So, look, depression can actually have quite serious consequences for people with cancer, well beyond the sort of, well-known consequence of poor quality of life. So, compared to people, the peers without depression, I'm sorry, Annabelle, can you excuse me 1 second to deal with this noise at my door? I'm sorry, just 1 second.
I actually have a noise at my door too because my dog is scratching at the door. But
yeah, that makes two of us. I'm so sorry. So what I wanted to say was that compared to peers without depression, people with depression tend to spend more time as inpatients in hospital. They're less likely to adhere to the treatment recommendations that are made for them, and they tend to experience more side effects with greater intensity. So on a psychological level, not only do you have poorer quality of life, but there's the chance also that your physical quality of life is impaired. Crucially, I think as a psychologist, when you're depressed, your ability to make meaningful decisions and to make meaning out of your experiences is impaired. And in the context of cancer, making meaning is so very important because that is really what buffers us from despair. So if, Sharon, if your depression is worsening, if you're concerned, I would really encourage you to reach out to your GP and allow your GP to refer you for some counselling.
Okay, so Leslie, is there a tendency, I mean, particularly among younger people who are shouldering this confronting load of new information and shock and surprise, is there sometimes a tendency to go, okay, this is a problem with my body, so I'm going to smash everything, and get every physical treatment that I can, and I'm going to feel miserable, and I've just got to get through it. I mean, what I'm hearing from what you're saying is that it's actually clinically significant to look after your mental health as well.
Yeah. Yes, I often say this on these sorts of webinars. Mental health is health. There is no health without mental health. So it's not a luxury. It's not an add-on extra. It is absolutely vital that we look after our mental health. And I think it's everybody's business. I think it's the oncologist's business, the surgeon's business, everybody's business to ask how women are doing and to be able to offer them referral and support as needed.
Okay, thanks, Leslie. Look, this might be a good moment to hop back to Emma. I mean, Emma, your response was to ring everybody, to kind of rally the troops. What was happening to your mental health? Did you listen to it objectively? What sort of support did you find helpful when you were first diagnosed?
I have always suffered from generalized anxiety. I didn't know what that was actually probably until I was in my early 20s, because I'm actually not that old, but I grew up in a time, at least with parents who didn't necessarily acknowledge their own anxiety, and anyway, and cancer actually helped me kind of reconcile it and deal with it, ironically. But I saw a psychologist, an excellent psychologist who, and not that much, but just enough to get some tips and tricks. And I also, this may be controversial to some people, but I just accepted the mental health drugs that was suggested to me, the benzos, the sleeping pills. And I'm saying this flippantly, but when you have to get through something and you've just got to put one foot in front of the other, and I think Leslie said, the adherence to treatment regimens decrease when you are feeling stressed and anxious and depressed. I just thought I've got a goal, which is to stay alive. So I just need to kind of start doing what I was told. And I was anxious. There's the anxiety again to take some of those medications, but it was life-saving for my own mental health.
That's interesting. I'm going to I'm just going to divert quickly back to Leslie. Sometimes when people are thrown into an urgent clinical situation where suddenly, you've got to come in on a public holiday, you've got to do this, take these pills and whatever, do you sometimes encounter a resistance from patients who feel kind of medication overwhelm and they don't want to take medications or drugs that are about their mental health? Do you find any sort of resistance to that?
I think that there is still a lot of stigma around taking medication, which is a real shame because medication can be so effective. And I think there are a lot of people out there have clung to myths and misconceptions that antidepressants can change your personality or that they're addictive, and these sorts of things that are not true. So yes, I think there is sometimes a reluctance. It's actually quite interesting, and Wanda probably hears this quite a bit. When women will say, "I don't want to put poison into my body," when they're having sort of systemic treatment for cancer, the least of their concerns is to add an SSRI, antidepressant, into that mix. But yes, there is something also about this thinking that giving in to taking a medication is not fighting hard enough. It's there's all this narrative around the battle that is cancer, which is also not very helpful. Yeah. But yes, there's a lot of stigma to break down, and often requires quite a bit of support and reassurance before women will accept medication.
Yeah, I guess that trope about being a hero that fights bravely and never cracks or feels like it's all getting on top of them is not a very helpful one. Emma, I wonder if, you're obviously still involved with breast cancer trials as part of the Consumer Advisory Panel, which has a really significant role in directing some of the research. Have you seen an improvement in support and resources for young women diagnosed with breast cancer since you were diagnosed? And are there gaps in that assistance, in your opinion?
I'm sure there will always be gaps. That's just the nature of these things. But yes, I had breast cancer in 2012, and social media was sort of at its coming of age. It seems like it had been around a while, but Instagram came about that year. Facebook, everything was building up a lot more. So there weren't a whole lot of online resources, or there were a lot of dangerous online resources because there was people with Instagram accounts saying anything they wanted, but sophisticated outfits like BCT and the cancer societies hadn't leveraged those platforms yet. So there were the traditional models of getting information, pamphlets and things like that, and you were given basically kind of like a tote bag full of 7,000 pamphlets for you to sort of weed your way through. I'm sure it was the same in Australia. You would get the Cancer Society, you would get Breast Cancer Aotearoa Coalition, which I'm involved in on the board of. You would get Sweet Louise, which is a metastatic outfit, and various and things from the Public Health Board. So then sit there diligently, probably, I assume I did, and split through all the pictures and try and distill some of the information, and maybe go and ask questions of your breast cancer nurse. Sure, you could go online, but websites weren't that sophisticated. So I think in that respect, it's become a long way. There are some fantastic apps out there from breast cancer foundations and things like that, where you can download them, you can access the information quickly and efficiently. There's still a place, of course, for that sort of hard paper and things for different generations. But I think for younger women, there's a plethora of really good information out there, and an easier way to distill or discern between what is good information and what is nonsense, because that's still out there too.
Everybody, I want you to get ready and remind yourself where those three little dots are, because I'm about to ask you a poll question. But before I do, or maybe while I do, if you go to that three dots at the bottom right hand side of your screen, you'll see our poll, and the question to you is: if you have been diagnosed with breast cancer, was it at 20 to 29 years, 30 to 39 years, 40 to 49 years, or over 50 years? And while you're busy fiddling around answering those questions, I'm just going to ask you quickly, Leslie. I mean, things have sort of escalated since Emma was diagnosed. If you jump online, you can find just an absolute proliferation across social media of people offering information, which is what people are sort of starved for and wanting when they're newly diagnosed. And it's also a really good way to scare the absolute bejesus out of yourself. How do you tell the difference between good information and bad information?
It comes down to the source. You have to be really judicious about the source of information. If you want to know something about your own cancer, and that's usually around your risk of recurrence or whether you're on the right medication because you've read something or heard something about someone else, the thing to do is to go to your doctor, to your oncologist, and have the discussion with the oncologist about your medication. In Australia, we're very lucky. We have BCNA, which is a treasure trove of resources and referrals and information on all sorts of things. We have the Cancer Council, similarly has wonderful resources, has a cancer helpline. So we do have a lot of resources, and we need to use those. If it's on social media, I would be disinclined to believe it.
Okay, thank you, Leslie. That is really useful advice, and thank you for those tips for links. We'll come back in a second to let you know the results of the poll. But in the meantime, I'm going to go back to Vivian with some questions from participants on this Q&A. Louise, to begin with, has asked if there are specific types of breast cancers that are being diagnosed more than others in young women.
Yeah, so breast cancer of any type can be diagnosed in any age woman, but I think in the younger women, we see an increased number of people with what we call triple negative breast cancers or HER2 positive breast cancers, which are breast cancers which may be more aggressive and a higher risk of recurrence in those earlier years after diagnosis. That's not to say that there aren't younger women also diagnosed with what we call estrogen receptor positive breast cancer, but those estrogen receptor positive breast cancers tend to be diagnosed in older women, be more slower growing. They can still have a risk of recurrence later on, sort of more after they overtake those more aggressive cancers in terms of recurrence after 5 years. But often we see these more aggressive breast cancers in the younger women.
Thank you, Vivian. I'm going to keep asking questions, and forgive me if it's obliging you to repeat anything, but I just want to ask very precisely some of these questions that our participants have sent in. Rebecca has asked whether you know what proportion of early onset breast cancers are linked to inherited genes.
Yeah, so I think about 5% of breast cancers overall are related to an inherited gene fault. And what that means is inheriting a fault from one or or either of your parents in a gene which if that copy of the gene that you get from that parent isn't working, then that increases your risk of breast cancer. And there are some very high risk, they're very rare, but reasonably rare, high risk genes like the BRCA1 and the BRCA2. And then there are some more sort of moderate risk genes like ones called PALB2 or ATM or CHEK2. These sort of these funny sort of names that these genes have. The important thing to know, though, is that it is only about 5% of all breast cancers. If it is found, though, it does have implications for the rest of the family, and I think it's called cascade testing. So then identifying who in the family is the right person to test, and doing predictive testing for those people, and it might be mother, sister, daughter, children, and those genetic faults actually are related also to other cancers as well. So somebody with a BRCA2 or 1 or 2 mutation or fault might also be at increased risk of ovarian cancer or some other cancers like pancreatic and prostate. So they do have a big implication for the family, and there are certain features of a breast cancer which might mean that the doctor or the treating team might investigate that person for a fault in one of those genes.
And just to be clear, does the proportion of early onset breast cancers which are linked to inherited genes, is that different from the proportion of later onset breast cancers?
So I think people who have an inherited breast cancer gene fault may be diagnosed at a younger age, and they also might know that they've got other people in their family. They might know already that their mother, grandmother, aunt, cousins. There might be, if you sit down with somebody with a BRCA gene fault in their family, there'll be a number of people diagnosed, and often those people are diagnosed at a younger age. Or there might be a man in the family diagnosed with breast cancer, but multiple people, and that really would be the sort of thing that might mean that a person might then be referred to a family cancer clinic for discussion with a genetic counsellor and consideration of genetic testing.
Right. Okay. Thank you. I'm going to ask you a question now that's come in from Ria, and we've talked briefly with Leslie about anxiety about breast cancer recurrence, which is obviously in younger women a concern that will exist for the rest of their lives. Is there any data on breast cancer recurrence increasing in young women?
Yeah, so the data question is very interesting. We actually don't collect national data on breast cancer recurrence. So we actually don't know exactly how many people are diagnosed with recurrence. We do know that there are some certain types of breast cancer that are more likely to recur in that first year or two. But there is a lot of work going on in data, and in fact Cancer Australia launched today a national cancer data framework because we need better cancer data. Every bit of data that we have on a person with cancer will impact what we know about cancer overall, and therefore can help us with cancer control efforts, with research and identifying, where do we need to put the resources. So we've recently had a lot of focus on trying to work out how many people are living with what we call metastatic breast cancer. That's breast cancer that's recurred. We don't really know how many people are living with metastatic breast cancer, but some recent data in New South Wales shows that 7,900 estimated 7,900 women are living with metastatic breast cancer. And the outcomes for people with a breast cancer recurrence with metastatic cancer are so much better than they used to be. As a result of the sort of trials that Breast Cancer Trials runs, and the sort of advances in what we call systemic treatments, so chemotherapy, targeted therapies, immunotherapy, the sort of therapies that Wanda and other medical oncologists provide, have really changed the outcomes for people with metastatic cancer. So whilst it is something, of course, that people worry about, and they and causes tremendous anxiety in terms of recurrence, the treatment options have really expanded.
Great. Okay. Thank you so much for that context, Vivian. Much appreciated. Wanda, I'm going to ask you some questions that have come in from our participants today. Paula has asked if fertility treatment increases your risk of breast cancer.
So this is a really important question, and there actually have been a number of studies that have shown that fertility treatments such as IVF do not increase your risk of breast cancer. And in general, actually, there have also been studies looking at women who have been diagnosed with breast cancer, including hormone receptor or estrogen receptor positive breast cancers, who then go on to have fertility treatment before they start their chemotherapy. And in those studies, there's also not been shown to be any negative impact on breast cancer outcomes or survival. However, the caveat to that is obviously, for any individual, it depends on your individual risk, it depends on individual cancer. And so it's really important to talk to your oncologist about your own risks and timing about fertility preservation if you have been diagnosed with breast cancer.
Okay, there's obviously a lot of anxiety about all these sorts of procedures and their relationship to breast cancer diagnosis. Jan has asked if mammograms can increase your risk of breast cancer, and is it safer to get an MRI for screening?
So actually, no, mammograms haven't been shown to increase your risk of breast cancer, but actually have been shown to significantly improve survival for breast cancer, because when mammograms allow us, or screening mammograms allow us to detect cancers at a much earlier stage when they are they're very curable. Nowadays mammogram uses very low doses of radiation. In fact, the average mammogram, the amount of radiation that's involved is about the same radiation as an overseas flight. Jumping on a plane overseas, we don't think about very often about the radiation involved, and certainly mammograms are now quite low dose. In terms of the question about MRIs, so we know MRIs are very sensitive, and therefore they have a much higher rate of what we call false positives. So that means detecting something that's not a cancer, but we can't be certain without a biopsy. And so an MRI for the general population is not recommended as a screening tool. However, in a small subset of patients, particularly those who have a very high risk of developing breast cancer, for example, someone who might have a BRCA1 gene mutation, MRI can be a useful tool in that setting, often in combination with mammogram.
Okay, thank you for all of that context. We've got a question through from Shane asking if there's any correlation of having had hormone-based medications at a young age, like acne treatment, for instance, and early onset breast cancer.
So Shane, I guess this is, an important question, because we know that hormonal treatments, so things like the combined oral contraceptive pill in young patients and in older patients who have gone through menopause, hormone replacement therapy, is associated with a very small relative increased risk of breast cancer during the time that you're taking the pill and for about 5 to 10 years after the pill. But it's really important to know what your baseline risk of cancer is at that time, to know whether or not that risk from the pill or any other hormonal contraception is relevant for you. So, for example, a woman in her 20s who has an average risk of breast cancer, who takes a pill for a few years, the increased risk from taking the pill during that time is almost negligible. And certainly if you weigh that a bit against the benefits of taking the pill from a family planning perspective, other medical conditions, as well as we know the pill can protect from ovarian cancer, that risk could be potentially quite negligible in that patient. So I think it's really important to first understand what your personal risk of breast cancer is. And you can use an online tool such as iPrevent to look at some of your risk factors, and it can give you an idea of whether or not you're at average risk, slightly increased risk, or high risk, and then talk to your GP about whether or not taking the pill is going to be risky for you or not.
Thank you for explaining all this so clearly, Wanda. You're really great at it. I'm going to conclude this bracket with a question from Edwina, who has asked what is the latest in research for triple negative breast cancer among younger women?
That's a very big question, Edwina. So, in short, there's a lot going on in research for triple negative breast cancer, particularly in young women. So, this is a really fast moving area. In the last few years, immunotherapy in combination with chemotherapy is now available to many women with triple negative breast cancer. We've also got access to PARP inhibitors. So, these are tablets that switch off the DNA mechanisms behind women who have a germline mutation in BRCA1 and BRCA2, and these are now also available. And there's also a lot of research into antibody drug conjugates. So these are targeted medications with a little toxic payload attached to them. And, there's been really good evidence that these are very effective drugs. And so there's a number of studies ongoing with these agents. And actually, breast cancer trials are running a number of these studies. So we know that now that we've got a lot of options, a lot of very effective options, there are studies now looking at whether or not we can safely de-escalate chemotherapy and prevent some of the unwanted side effects from chemotherapy. And breast cancer trials is leading the way. There's a NEON trial looking at triple negative breast cancer where we're giving more immunotherapy and less chemotherapy. And this is not triple negative breast cancer, but in hormone receptor positive breast cancers, we're now looking at using PARP inhibitors and antibody drug conjugates in this group of women. There's the OLEO study currently that Breast Cancer Trials is leading, looking at PARP inhibitors and immunotherapy in premenopausal women with DNA changes in their breast cancer. And Breast Cancer Trials is also leading a study called Optima Young, looking at whether or not we can de-escalate chemotherapy in young patients who have hormone receptor positive cancers as well, using genomic testing.
Great. Thank you so much, Wanda. Just a reminder to everybody participating, this session is being recorded and it'll be emailed to you tomorrow. So if you've been unable to find a pen while you're trying to jot down all of this information, you do have an opportunity to revisit and reconfirm what it is you heard that you thought sounded interesting or relevant to you. Now, I'm going to go back to you, Leslie, because people on this webcast today are at various different stages in this story. And while obviously post-diagnosis, the number one concern is, okay, what are we going to throw at this thing? How am I going to get rid of it? There's also a path back to health that can be rocky for some. And Michelle has asked, what support is there for patients as they make that transition after treatment? And where's the best place to look for that kind of support?
Yeah, so I think, as I said before, the Cancer Council information and support line is a very good resource, and BCNA also has peer workers that can provide support. There are other groups in the community that have lots of online programs that range, I guess, from the educational to the more recreational organizations like Think Pink. There are groups online that are specifically for younger women. There's the Cancer Chicks. I forget what the cutoff is for Cancer Chicks. I think it might be 35. If women need something more than peer support or booklets, then there is an online self-help resource called Finding My Way that's worth a look at. And there's also the Cancer Mind Care platform that provides resources for a sort of a personalized plan to address distress. But if you think that you need more than this, that your needs are beyond this, so in other words, the symptoms that you're having interfere with your daily functioning, they interfere with your ability to work, your ability to parent, then it's probably appropriate to talk to your GP or when you go back for one of your review sessions in the oncology team, to talk about a referral to a psychologist. If you're with a GP, to think about whether you should perhaps commence an antidepressant medication. And I think just to bear in mind that under the Better Access Initiative here in Australia, we can access 10 Medicare rebatable sessions in a calendar year. So that means from the 1st of January until the 31st of December, you can see a psychologist or a clinical psychologist 10 times, and that those 10 sessions will each attract a rebate. And of course, now with telehealth being approved by Medicare, this means that people who live outside of metropolitan Melbourne or on the other side of town to the person they'd like to see are now able to access that care.
Okay, that's a really good tip, Leslie, and I think it's worth just reinforcing that even once a physical or clinical crisis has sort of passed, it doesn't mean that you're being indulgent or selfish or weak to still be struggling with the dimensions of what it is that you've been through and will continue to go through. Just quickly, Trish has asked how you stop or reduce the fear that breast cancer will come back. Obviously, that's a massive area of concern for people who have gone through treatment successfully earlier in their lives. Do you have any quick top tips to offer for Trish?
Look, it's so common, the fear of recurrence or the fear of progression, and it can be so disabling and also so lonely because often people around you and you yourself want to move forward, but people around you think your cancer experience is well behind you, and it's just not as simple as that. And of course, it's really difficult when there are reminders of cancer everywhere. There are pink ribbons in the grocery aisles and there are pink billboards. So we're reminded all the time. We can treat worries about recurrence, but we can't eliminate it entirely. And that's because it is actually a very normal reaction and a very normal thought. Even if you have had the earliest breast cancer possible, there is no 100% guarantee that it will not return. So it's not an entirely irrational thought. The other thing to keep in mind is that our minds, our brains are wired for survival over happiness. That's how we've evolved. That's how we've guaranteed our self-preservation. So your brain is always going to be predisposed to focus on potential threats to keep us alive rather than on positive emotions. And that vigilance is actually necessary and adaptive most of the time because it allows us to follow up with our care and to look after ourselves. But it's the intensity and frequency that become a problem. If you're having thoughts about recurrence that are impacting on your quality of life, then you do need to get help because the data shows us that that won't go away by itself. So I'll just give you a couple of quick things that I think you should do in terms of helping to manage thoughts about recurrence. One, again, talk to your doctor, discuss your specific risk of recurrence with your doctor in relation to your cancer. That can also help you differentiate in this discussion between normal aches and the sorts of signs of cancer that you might need to look out for. The other thing is manage your side effects, because when you've got side effects that are not well managed, you're hypervigilant towards those, and there's the possibility that you interpret those as something that they're not. Focus on what you can control is a big thing. Actively doing your follow-up care, making those positive lifestyle changes. Others have talked today about alcohol and weight. Those things are really, really important. And in addition, take up something like yoga or mindful meditation, because what those types of interventions do is they allow you to observe your emotions without labeling them and without allowing them to take over your life.
Great, thank you. They're all great pieces of advice. Obviously, women are trying to come through all sorts of fears around fertility, around mortality. Lillian has asked, is there any specific support to help young women get back on track with their careers and earning an income after breast cancer?
It's a great question. I think there was a recent report showing the huge productivity burden that's associated with breast cancer. I think it said something like women lose about 1.5 years of full-time work after diagnosis. So yes, it's a big problem. The Cancer Council again and the BCNA have resources and fact sheets to assist with returning to work and understanding your legal rights and your employment rights. And the Cancer Council can also refer people for financial counselling. Another, I guess, bit of advice is to speak to your care team, often your oncologist, about supporting a graded return to work. In other words, if you were working full-time previously and you're off work for a year, that you don't go back immediately to full-time work, but that you sort of you step back into that slowly.
Okay, great. Again, I think the message there is if you're feeling a certain way, it's okay to feel a certain way and to acknowledge that and not feel ashamed or embarrassed or weak for feeling in that way. Emma, feels like a good time to come back to you. What sort of financial impact did breast cancer have on you as a young woman?
Well, I guess the answer to that is sort of twofold. One is I couldn't afford not to work or not to keep working. I was working full time. I had a 4-year-old and I had bills to pay. So I continued to work. The second part of that is that I had medicines that weren't and remain unfunded in New Zealand. And I wouldn't have been able to afford them without support or a loan. And I had that support from my parents, so I'm really lucky. So it's a huge impact on some people though. And I probably would have continued to work in some capacity because I found that a coping mechanism to continue some sense of normality, but I didn't really have a choice.
Okay, and you also had a young child. Can you just quickly tell us how you grappled with all of those other questions about fertility, your whether you'd be able to have more children? Was that something that preyed on your mind?
No, because it happened so rapidly. The conversations about that were so urgent and happened so rapidly. I had to make sort of instantaneous decisions. And I remember sitting in my oncologist's office, maybe, I don't know, on the Wednesday, having been in on the public holiday on the Monday, and him saying, well, you're only 24, you should do you want to think about having some eggs frozen? I don't really want to alarm you, but that'll take about 2 weeks. And I'm not really sure that's a good idea. Like 2 weeks is not could make a material difference to your overall to the end point here.
Wow.
I had my parents with me, and I was like, "Well, don't say no more. I've got one. I have to stay alive for the one I've got." And I said something to the effect of, "Don't worry about it. If I want more, I'll just adopt one," which is really callous. But in the moment, I mean, I don't know, to your point, Leslie, it's a survival instinct, right? I am a self-centered human being. I wanted to survive, and I wanted to survive selfishly for my child that I had alive. So I didn't have the luxury of time, so I had to make a really practical, ruthless decision.
Yeah.
And fortunately, and then it turned out 10 years later, not quite 10 years later, I didn't do any fertility treatment. I hadn't frozen any eggs, and during COVID we had a baby, and she turned 5 on Monday. So,
oh, that's wonderful, Emma. Thank you. And I think I would be remiss if I didn't say to you, because I can sense everybody on this group just screaming at it. It is not selfish to want to survive, to be there for your 4-year-old. That is not a selfish instinct. Even just wanting to survive is not a selfish instinct either. And I think on this day, your birthday, everybody would like me to say that to you. Okay, so what concerns do you hear like most commonly from other young women diagnosed with breast cancer and about the impact that it has on their lives?
That's a really good question. I don't know that I hear that many about the impact. I mean, it has impacts in terms of and Leslie might have mentioned this before, in terms of vanity is not the right word, but physical appearance and stresses like that. But also most commonly hear about the impact from young women is that, and I don't think it's as bad now, but there is this perception still, and because I think of much of the marketing that is done around breast cancer, that it doesn't affect young women as much, so they still feel, I think, a little bit on an island out on their own.
Yeah.
And I think that is an impact on their life, because it impacts their and there are peer support groups online, and sometimes they're really good, and actually sometimes they're really bad, because everyone's really stressed.
Yeah.
And people use it as an outlet. So
yeah, and feeling like you're the only young person in a waiting room makes you feel like you're an outlier of some kind, I guess. This feels like a good time to just check in on our poll results, and they have come through. Among our audience watching today who responded to this poll, 42% of viewers were diagnosed with breast cancer over the age of 50. 36% diagnosed between the ages of 40 and 49 years, and 20% diagnosed between the ages of 30 and 39. And a very small percentage of people watching today were diagnosed in their 20s. So that's the proportions in our participating group this afternoon. Now, I'm going to come back to you, Vivian, because Breast Cancer Trials has received a number of questions about the impact of the COVID vaccine on increasing numbers of young women diagnosed with breast cancer. Now, obviously, in Emma's case, COVID caused her to become pregnant. That feels like an outlier impact. But is there any evidence that the COVID vaccine causes breast cancer? I'm asking because everybody's got a theory. Everybody from the US Secretary of Health to Pub Galah has got an opinion on this. So COVID vaccine, breast cancer, go.
Yeah. So, Annabelle, there's absolutely no evidence that the COVID vaccine is a cause of breast cancer or related to the early onset breast cancer. What is really important, though, is that the COVID pandemic was a big disruptor to the provision of cancer care. So it interfered with cancer screening. So many of the breast screen services closed down during COVID. It interfered with people going to the doctor with symptoms and timely diagnosis, because, people were worried about other things, didn't feel like they wanted to worry their doctor, or didn't actually want to go to the doctor. And we did see a drop in numbers of people being diagnosed in 2020 and 2021. We also know that it was really hard for people who were diagnosed during COVID, because, of course, those restrictions really stopped or impacted on the way that people received their care. So we do know that COVID had an impact, but not because of the vaccine, because of the actual pandemic and its restrictions.
Right. Okay. Thank you. I'm going to move back to you, Wanda. There's a question from Julie, who wants to know, what are the chances of daughters being diagnosed with breast cancer if there's a confirmed genetic mutation in the family, like ATM or BRCA?
Well, I guess it would depend on whether or not your daughter has inherited the gene in terms of what her risk may be. So, for example, Julie, if you had one of these gene mutations, there is a 50% chance for each of your daughters, as well as each of your sons, that they could have inherited this gene mutation from you. So for your daughters who have inherited this gene mutation, or your sons who have inherited this gene mutation, their risk is higher. And if they hadn't inherited this gene mutation, then their risk is not as high. So I think the first step, as Vivian had highlighted, if you have this gene mutation, is cascade testing and testing your family.
Great. Thank you, Wanda, and thank you for reminding us that when we're looking at family heritability, we're not just talking about daughters, we're talking about sons as well. There's a question from Gemma, who says that she was diagnosed at 36 years of age but doesn't have a genetic mutation. She's wondering whether it's possible that there are dormant gene mutations that science just doesn't know about yet that could cause breast cancer in younger women.
Yeah, so as we've highlighted this evening, we know that only a minority, about 5% of breast cancers, are due to changes in single high-risk genes, such as BRCA1 and BRCA2. There's also some moderate risk genes associated with breast cancer, and depending on when you were diagnosed, Gemma, and the panel that they use at the time. These genes may have already been tested, or they may not have. So some panels only test for BRCA1 and 2, and some test for other genes. But there's also some increasing work around something called polygenic risk scores. So these are just changes, small changes in hundreds, multiple, very common genes called SNPs. So these are single nucleotide changes. And each single gene change may only confer a very, very small, if negligible risk of cancer. But if you add them all together, then it can potentially increase risk of cancer. And certainly there's a lot of research going into polygenic risk scores at the moment. So this hasn't hit main time, but certainly something that's been researched.
Okay, there's a question from Joe, and I excuse me. I noticed this week that the US Health Secretary announced the removal of product warnings on hormone replacement therapy, advising of an increased risk of breast cancer. Joe wants to know if HRT does increase your breast cancer risk. Can you give us a quick opinion on that?
Yeah, so just very quickly, very similarly to the previous question about oral contraceptive pill. So we know that exogenous hormones can slightly increase your risk of breast cancer, but very different to the pill, which is often used in younger women. Hormone replacement therapy is often used in older women. And we know that one of the biggest risk factors that's non-modifiable for breast cancer is increasing age. And so I guess again, very important to know what your current cancer risk is now, and then calculating what your relative increased risk is, and working out the risk for you. Also, it's really helpful to speak to your GP about non-hormonal options for menopausal symptoms, as well as consequences of menopause, such as bone strengthening agents as well.
Great. Thank you so much, Wanda. Speaking of menopause, Leslie, Karina has asked how we can support young women who are put into menopause as a result of treatment. We know that this is can be quite a confronting process for younger women who are being treated for breast cancer. What are the best ways of handling the issues raised by that kind of treatment?
Yeah. Look, I think we need to recognize the tremendous grief and frustration of feeling older than you are and undergoing changes to your body that are very premature. And I think we have to give women the space to kind of to mourn the loss of that identity and the reconstruction of another. We need to ask women about these symptoms, and then we need to offer them safe symptom relief options for the hot flushes, the night sweats, the sleep disturbance, for the impact on their sexuality, the impact on their mood. And those options, as I said, can be pharmaceutical, or they can be in the form of evidence-based psychological therapy. There's actually very good cognitive behavioral therapy for the vasomotor symptoms, though that component of the hot flushes and the night sweats. And there are also some complementary interventions that have an evidence base, like acupuncture. So, it is very common. There are more women with hormone positive cancers, so there are more women who are taking hormonal manipulation medication, and many of them suffer in silence, which is a problem.
Yeah, I remember from past panels on side effects and sexual side effects that that there was a lot of evidence that breast cancer nurses are an amazing fount of information on this stuff. So the trick is to not be embarrassed about asking questions. Oh my gosh, my dog is really going nuts at the door there. So just quickly, Zoe has written in to say that just like Emma, she was diagnosed with breast cancer at the age of 24. And she asks, this is, a tough question to read out. She says, how do you continue a happy, healthy life when there are no answers as to why you were diagnosed and there's no family history?
Yeah. Look, I mean, it is very sad to hear women ask questions like this and to reflect on the experience of sitting with those questions. And I said earlier that we may never know why, but we can still choose to choose how we live going forward. And set small and sort of achievable goals for recovery, for joy, to sort of celebrate milestones, and, very importantly, to allow yourself grace and compassion as you recover from this, because recovery is not a linear experience. It's not sort of, well, treatment is over now, so I'm going to get this party started again. It's a sort of an up and down process where there are good days and bad days. So, I try to encourage women to think of a happy life, as it were, as something that is new, something where you've taken what you can from your experience of cancer and you've shaped that and modeled that into something that works for you going forward.
Great. Those are super wise words. Thank you, Leslie. I've got a really simple question to throw to Wanda from Caroline. What can young women do to reduce their risk of developing breast cancer?
So I think the first point is to know what your risk is, because if you don't know that you're at increased risk, then it's very difficult to know how to reduce your risk. I guess in general, there are modifiable risk factors such as lifestyle changes, alcohol, maintaining a normal BMI, breastfeeding if you want to and if you can, and use of exogenous hormones. But in women who do find that they are at increased risk of breast cancer, medications that might reduce your risk of breast cancer, and in a small proportion of patients who are at very, very high risk, even surgery to prevent breast cancer may be suitable. I also think, just taking a bit of a step back, I think as society we also have a bit of a responsibility as well. What we saw with tobacco campaigns that reduced smoking to reduce risk of lung cancer. I think, as a society and as governments, we can certainly look at ways that we can reduce exposures to risk factors for breast cancer across society, and also things like improving maternity leave policies that allow women to breastfeed for longer if they choose to. I think those are also strategies that I think we should be looking at too.
Great. Okay, thank you. As you may have sensed, we're entering the quickfire round of this Q&A. I'm determined to get Emma back to her own birthday party by the appointed time. Vivian, what steps is Cancer Australia taking in response to the trends that you're seeing in terms of early onset cancers, including breast cancer?
Yeah, look, I think, as the lead cancer agency, where we are the government's cancer control advisors and agency, and we've identified this early onset cancers as a strategic priority. So bottom line is that we need to know more about the evidence. So we have commissioned the University of Sydney to do an evidence review, find out for us, what do we know about this increasing incidence? Are there any risk factors out there that we don't know about? What do we need to, where are the research gaps? We're also working with looking at the way that GPs diagnose cancer in younger people, and actually making sure that there is sort of more awareness of those symptoms and investigating symptoms, including investigating a new symptom of breast that might be breast cancer, and doing that in a sort of a systematic way. And then the other thing that we're doing is we've partnered with the National Health and Medical Research Council, the NHMRC, to fund research into early onset cancers as a strategic priority. And what we really want to know is, what is out there in terms of risk factors that we don't yet know about. What do we know about the causes? But also, how do we reduce the impact of early onset cancers on people? What different models of care, what are the needs and supportive care needs that we really need to be addressing, so that we can actually improve this for the whole sector moving forward.
Okay, if I can crisply summarise the advice from Wanda and from you, it's know your risk factors, reduce them where possible, and get to know your boobs. It's never too early, right? Okay. Thank you. I am going to end with Emma, because Emma's where we started and she's kind of the face of what we're talking about tonight. I just want to know, firstly, how are you feeling a decade after your diagnosis?
I feel great. And I don't say that to show off. I actually want to say that to demonstrate that there is life beyond it. And you said earlier, Annabelle, oh, it actually might have been you, Leslie, and sorry, but someone said, you want to move on and people think you've moved on. And for me, I wanted to stay around in this area and do some work and do some mahi in it. And I'm glad I did. And that comes with its own trials, because I haven't allowed myself in some respects to move on completely, but that's been really good for me, and that's got me to a place where I'm really happy. I'm grateful, and I have a party every year, either by myself or with lots of other people. I try and do it with other people, but I think it's important to celebrate, and I think it's important to yield to what you cannot control and control what you can, which is celebrating.
Well, it sounds like you're a slightly different person from the Emma who couldn't be told anything of those 10 years ago. And I want to just thank you on behalf of everybody who's on this call for sticking around and using your experience to improve outcomes for others. And in closing, I'd just like you to say, if you can think of anything, what your hopes are for the future in breast cancer.
Oh, look, I'm an optimist and I have big aspirations. I want breast cancer to be a chronic illness that, well, one is cured at early breast cancer. We know it can be, which is amazing, but I want every woman who's diagnosed with it, particularly those with metastatic cancer, I don't want it to be a death sentence anymore. I don't think it has to be, and we're moving quickly towards that, and it aligns with BCT's own goals. And I'm just going to go off script here. I just want to say one thing to Zoe, because she talked about how to live a healthy and happy life, and I just say, keep going, honey. You just got to keep going, because one foot in front of the other, you do get there. It's hard. The anxiety and the recurrence fears never fully leave you, but you can manage them, and the further away you get, it does become easier. So you just got to keep going.
Emma, thank you so much for bringing your energy and your insights to this discussion. It's much appreciated, and everybody who sticks around and everybody who participates in trials as well commits a part of themselves to helping others, and that's an extraordinarily generous thing to do when you're undertaking or undergoing a really significant life event. I'll remind you that Breast Cancer Trials also runs on donations to keep research cutting edge. So if you are inclined to get onto the website and help in that way, then it's very much appreciated. And we are out of time. 1 minute into Emma's allotted birthday party time. Sorry, Emma, but thank you so much for joining us tonight. Thank you to Vivian, Wanda, and Leslie too, and everybody who joined us today and asked questions. A reminder, this whole thing has been recorded, so you'll be able to scroll back when we send you the link tomorrow. It'll also be available on the Breast Cancer Trials website tomorrow, so feel free to advise anyone who you think could use some of the information that you've heard this evening. Breast Cancer Trials, as you know, is committed to improving outcomes for every person diagnosed with breast cancer through research, and it's through attention and the kindness of these professionals that we're able to reduce the burden of fear and ignorance and just general panic that can be associated with starting out on this journey. Everybody, I wish you a wonderful evening, and in particular to Emma, a happy birthday. So pleased that you are with us. Thank you for watching. Goodbye.